health kinds of issues. So, if you look at this, well, development, collaboration, impact road safety, maternal health, role importance, engineering, et cetera, all these things, eye care, all these things really involve people. They involve human beings. It may be through other kinds of interactions, but they all involve people. And so global health really is, in many ways, even though the end product is health of people, earlier in the process, it also involves people. This is interesting, I think, and it's our neighbors to the north, the Canadians, or actually where I am to the west, or to the east, the Canadians. And it's, even though it's just Canada, it's a nice slide because it makes a really important point. When you think about what the contributions are to illness, any kind of illness you can think of, here's the Western biomedical tradition. I'm superbly trained in diagnosis and treatment of pathology, but that's not all there is to health. And in fact, that's a minor contribution. Now, it may be that ultimately many of these things act through biology or some interaction with biology. But if you look at this, your life, well, what's your life? It's all these things. Income, early childhood development is a big deal. So in Malawi, you go to Malawi and you see 5-year-olds, and they look to me like they're 3-year-olds. You see, in the United States, 5-year-olds are bigger, and that's stunting. That stunting has huge consequences for later health, cognitive development, all kinds of other development, and just later general health. Obviously, things like education, social exclusion, let's talk a little bit about the safety net. Certainly gender is a tremendous issue in many parts of the world, tremendous. Race, in Canada, they talk about the First Peoples, so Aboriginal status, the first people that were there. Food, of course, food security, all these kinds of things. That's a huge contribution. In fact, there's a study done in Africa in the Amboseli with baboons. And what the researchers there documented was that if you're a baboon, and you're born into a family where you have, say, 3 or 4 siblings, or you're born into a situation where there's famine that year, your life expectancy is about 10 years earlier than it would be if you're not born in that circumstances. So those early kinds of impacts, what some people will call ACEs, or adverse childhood circumstances, adverse childhood experiences, have tremendous impact upon the rest of your life. Child and adolescent psychiatrists have known about those things for years. Your health care, also a big chunk. Can you get health care when you need it? Access to health care. There's biology, genetics, air quality, civic infrastructure. Well, you could actually transfer that and call that your life too. Air quality is an interesting thing. For years, of course, people thought about air quality as well. If there's particulate matter in the air, it's really bad for your lungs. It turns out it's much more significant than that. Particulate matter that gets into your lungs is really pro-inflammatory. And so it causes all kinds of general inflammation and maybe implicated in things like depression, as a matter of fact. So these are much more significant things than we may have thought in the past. So all this, when you talk about global health, all these things are incredibly important. Another way to look at this, determinants of health. Well, again, as a Western physician, I'm superbly trained in really physical health. And in my case, emotional health, because I'm a psychiatrist. But if you got to me in medical school and said, well, what's social health or what's spiritual health? I wouldn't have much to say about that at all, because they weren't really part of my training and they weren't really part of my tradition of medicine particularly. But in fact, they're tremendously important in Western societies, and perhaps even more spiritual health, perhaps even more important in Eastern societies in many ways, because in the West, religion and church attendance and those sorts of things has really gone down tremendously. So those kinds of things are not things that I would have thought about, but I think about a lot now. Let me give you a couple clinical vignettes to illustrate some points. So this is when we were doing some research in Africa. And it was a particularly interesting piece to me. So a mother brought her 4-year-old child to our research program. We were looking at really psychiatric and neuropsychological issues in children who had recovered from cerebral malaria. And in Africa, in Malawi particularly, cerebral malaria is a disease of young children, ages maybe 6 months to 3 years or so. The median age is about 3 years, as a matter of fact. So these are generally young kids when they come in. When we asked through our interpreter what her understanding was of what caused her child illness, she reported that the doctors told her that this was malaria that got into her child's brain. And she had to believe this because that's what the doctors told her. But she went on, spontaneous comment, she really thinks it's because a man in the village was upset with her family and did something really to cause the illness. Well, so she had these two very different explanations in her head. One was a biomedical explanation, and one was a much more spiritual kind of explanation that may have had to do with curses or a variety of other things. And very interesting, she could hold these two in her head. Beyond that, the relevance of this is that perhaps when you're talking to her about follow-ups and treatment for her child who had some disabilities afterwards, she may or may not follow up on that depending on which of those explanations was most cogent for her. If it was a man in her village who really caused the illness, she may go off on a very different pathway. So this is an individual explanation, but what it points out is that cultural issues are tremendously, tremendously important. And one size kinds of prescriptions don't fit all individuals or all settings. One more. A shaman was consulted about an individual in a village, this is in Central America, who had an illness. The shaman did the thing he usually does, which is he gathered the village people in the central area of the village, performed a series of rituals. The sick individual, he then announced the sick individual was cured. And in fact, the shaman was a guy named James E. Naidu, who looked, this is not him, but he looked very much like this. He was a man with a white beard, white hair, really piercing eyes. Very, very charismatic. And what was the function of what he did? Well, what he did was really, he mobilized the village, society, to declare that the individual was cured. And now there's tremendous social pressure on this individual, really, to begin to act in ways that were not in a sick role. And I'm sure that he was smart enough to know who he could do that with and who he couldn't do that with. So in some cases, he would bring people into the village square and do this with the village. In other cases, he wouldn't. So he knew, he had some idea that this would work in this kind of setting. So this is another way of using culture and using the local community to help cure individuals. So very culturally different than anything we would do. In the United States, if we thought, in my tradition, if we thought the sick person had a psychiatric disorder or a conversion disorder or something like that, we would think about medication and we would think about perhaps individual psychotherapy. We would probably not gather the village and perform rituals. So it's a very, very different kind of thought process. So thinking about global health really increasingly, and especially today, I think, requires thinking beyond very traditional public health boundaries, public health departments, schools of public health, and that sort of thing. And let me make a point about this. This is Merida, Mexico. And this is the great cathedral in Merida. And this cathedral is the second oldest Catholic cathedral in the Western Hemisphere. And it was built in the city of Merida. Merida was a native village before the Spanish came in. And the Spanish came in, of course, and did what they do, which they destroyed the village and built their own. And the cathedral is built with the stones from the village. And so Merida is one of the oldest continuously inhabited locales in the Americas. And we did a couple of projects in Merida, which I'll talk about in a minute in terms of what worked and what didn't. So let me talk about lessons learned. First is the culture eats strategy for lunch every day. And this is attributed to the great management consultant, Peter Drucker. And so he was really talking about corporations and change in corporations, which have particular cultures, but this applies very well to global health kinds of issues. You can't go in and impose your own culture in a global health setting because culture will eat whatever strategy you have for lunch every day. You have to go in and you have to be sensitive to, and you have to understand something about the cultural issues. Now, none of us can be knowledgeable about every single culture out there, but all of us can be sensitive to cultural issues. And when you're dealing cross-culturally in these kinds of, in any kind of setting, you know a couple of things. One is you kind of have some idea what you know, but there are lots of unknowns. There are lots of things that are going to go right over your head and you just won't understand them at all. And you have to be cognizant of the fact that that's the case. If you're working with people from the locality and you have a good relationship with them, that can help tremendously. But otherwise, you just have to understand that you're the local, you're now the naive person. You're the person who doesn't understand things. And so in that, and let me give you just a little small piece of that. So the first time I went to Africa, we had a place we were staying and we walked about a mile to the hospital, Queen Elizabeth Hospital in Blantyre, Malawi. And I was the one white face surrounded by a whole bunch of black folks. And I was pretty intimidated because this is an entirely different notion to me. And I didn't know the rules. I didn't really understand what was going on much. But once you've been there, for a week or so, you kind of begin to figure things out. And you kind of begin to see that this is fine. And as long as you understand a little bit about what's going on, you're going to be just fine. In fact, there's MRI data that also shows us that you can adapt. So humans grew up in very different cultural settings that we're in now. We basically grew up in hunter-gatherer groups, and in a hunter-gatherer group of maybe 30, maybe 40 people, you knew kind of everybody in the group or something about everybody in the group. Anybody outside the group that came in was by definition dangerous until you got to know something about them. So when you put people in an MRI and you do a functional MRI and you look at their amygdala and you show them faces of people from other cultures, their amygdala lights up. People from other ethnicities. When you show them pictures of people from their own ethnicity, their amygdala doesn't light up so much. That's probably an adaptation over many, many years living in hunter-gatherer groups. That's probably not so great. However, if you continue to do that and you continue to show people of other ethnicities to an individual in the MRI, their amygdala lights up less. So people can adapt. You can begin to see those others as not so dangerous. And so that's a more optimistic piece. And that's what happened to me. I began to adapt and I felt much better about things. And then I made some friends and that was great. So global health interventions have to address human dysfunction. Remember that the majority of illness is not really caused by microbial or other pathogens. A lot of it is, but a lot of it isn't. Many of the things you're talking about in your conference are really not caused by microbial pathogens, caused by other things. Environmental phenomena are a big deal. In some parts of Africa, there's a disease called Kanzo, and Kanzo is a lower extremity paralysis. And one of the major food is a kind of tuber, and it picks up arsenic that's in the soil, and it's got to be processed in a certain way. Well, in situations of drought, maybe caused by global warming, you can't process those tubers particularly well. And so the incidence of Kanzo increases. That's the environment. And that's a huge global environmental problem. Poor coping skills, another huge problem. Food insecurity, housing, little ability to advance. This is often called deaths of despair. So in a setting where you feel like you are trapped, you have no way really to better yourself, economically, socially, whatever it is, sometimes people end up dying, and they end up dying because they kill themselves, or they end up dying because they neglect themselves, bad things happen to them, and so on. And some people call these deaths of despair. In fact, Angus Deaton, who's an economist, and his wife coined this term, and they coined it really based on looking at suicides in the United States around drug abuse and that sort of thing. Certainly drugs of abuse and access and quality of care. All those are important concepts, important things to think about. And that's nowhere near a major listing. Local issues. Well, again, if you spent any time in other cultures, if you don't understand these things, you're not going to get very far. Maybe what you're really interested in is treating the disabilities that come from cerebral malaria. Let's say it's inattention and hyperactivity by using a stimulant like Ritalin. But maybe the community is interested in something different. Maybe what the community is interested is in that these kind of impulsive kids don't throw rocks at the goats and irritate people. And maybe that calls for, maybe medication is useful, but maybe it calls for some other interventions. Who in the community decides? Well, you know, in a Western tradition, it would be you, the individual, decides. That's who we work with. In other cultures, maybe not. Maybe it's the elders in the community. Maybe it's the elders in your family. What's the best way to go about this? Well, in a good Western medical tradition, we just jump right in and do something. Maybe that's not the best thing to do. Who do you work with? Well, maybe you have to ask people who you work with. You have to ask the community who you work with. And what do you leave behind, which is often called sustainability or capacity building? And that's a big deal. And that's really in many ways, a moral issue. And the moral issue is, do you come in, do your research or your intervention, and then leave? Well, if you do that, maybe you've made some progress, maybe you've helped some people, but if you haven't left anything, then what do you got? Maybe that intervention, whatever, dies out after a while, or maybe you didn't leave anything. You collected your blood samples and whatever, and you just kind of left. That's probably not so wonderful. You know, capacity building is continuing and improving the interventions or the skills or the knowledge. It also requires things like dedication, enthusiasm, and ultimately you've got to have, somebody has to have a deep understanding of the culture, and that's probably not you. That's probably the local people. So let me talk about that a little bit. And so again, just a personal look at what I've done, and things I think have worked and things I think haven't worked in the context of other cultures. So one of the things that's really worked tremendously well is Dr. Abbasi's Muslim mental health conferences. Again, what she did was really a very kind of remarkable thing. She got some money from the American Psychiatric Association when she was a psychiatry resident, and got this fellowship. And so she put on this conference, and she put on one conference, and it was really interesting. And then she put on a second conference, and it was really interesting. And then we looked for other money, and we were able to help her put on more and more conferences. And the conferences really became a focal point in the United States, with really a national reach around bringing together individuals who were concerned with Muslim mental health issues. And she was even able to bring in other people, non-Muslims, who were not necessarily well thought of in the Muslim community. An example is law enforcement. She was able to bring in some people from law enforcement. And this was earlier, back when we were still very, very concerned in the United States with terrorism kind of issues, you know, from those other people. And the Muslim community in the United States was really pretty concerned about how law enforcement looked at them. And she was able to bring law enforcement in, and they were able to have a conversation and not just yell at each other. So it was one of the few Interesting settings where you could actually have that kind of interchange. And the conferences became more international. For example, your conference, a little piece of this is in relation to the Muslim mental health conferences we do. Here and elsewhere, we've done them in Malaysia, we've done a piece in Jordan, and so on and so on. And it required somebody who initially came from a different culture to be able to really set that up, and who really is a person with experience, with deep experience now in two different cultures. That was one. Another one that worked really well was our relationship with the Jordanian Royal Medical Services. Jordanian Royal Medical Services is the Army Medical Services in Jordan. And what we were able to do was initially through a conference, which I got to because of Dr. Abbasi, the Common Bond Conference, I met a psychiatrist from the Royal Medical Services who was very interested in putting on, well, very interested in education and very interested in bringing people over to talk about certain kinds of therapies, cognitive behavioral therapy and other things. And so we decided we were going to do that. We did that together. And as the relationship grew, the Royal Medical Services became interested in sending their psychiatrists and their trainees to the United States for kinds of training that they couldn't obtain in Jordan. And so we've done that. Turns out it was interrupted by COVID, but we did it before and we'll do it again afterwards. And so that's an ongoing relationship that's worked really well. Bringing people over to our residency has been incredibly enriching. To bring people over from a different tradition, different culture. And in return, they get good training in areas that they couldn't get before. And so they take that back to Jordan. And so now we have a lot of friends in Jordan. And so the process becomes self-sustaining. That's worked really well, and that's capacity building. And it's good for them, and it's really good for us too. On the other side, things I think didn't work very well. So I talked about cerebral malaria. And so over a couple of years, we did this cerebral malaria project in Malawi, and we were able to document that there were some really adverse neuropsychiatric outcomes of malaria in Africa. But try as hard as we did, it was really difficult to leave anything of that project there. And I'm not sure why. We had an enthusiastic co-participant in the only local psychiatrist in Malawi, the only Malawian who at that point who was a psychiatrist. And in fact, he was the guy who originally made the observation that allowed us to do the project. But for reasons like he was way too busy, I guess is really the only Malawian in the country. He was really the government psychiatrist, and he was running a private practice, and he was running the psychiatric hospital. He really didn't have time really to work on this project. So what did we have? Well, we had us and we had our interpreters who were also great people, but didn't have the capacity to carry on the project. So that's a project that really, we didn't leave anything. Wanted to, but it was just very difficult to do that. And the second one that didn't work well was, well, I mentioned Merida and some projects down there. And the one I wanted to mention that didn't go so well was an interchange we had with their psychiatric hospital. And that was, we would go down and lecture, and they would actually come on video, and we would provide some lectures to them. That just kind of died out after a couple of years too, in part because in Mexico, when the government changes, the personnel change down to the hospital leadership and also to the hospital leadership that are running their psychiatric training programs. And so there was no continuity. And we weren't able to be there enough, I think, to build the kind of personal relationships on a long-term basis that would have worked in that setting. So in neither of those cases did it work so well. Now, interestingly, we're doing some more things with some folks in Merida now, and so we have a chance to try to address that issue. So some things work really well and some things don't work really well, and I've been involved in both. So the moral of the story is, one, someone has to want to change. And the people that have to want to change are local. We can help, but they really have to do it. There have to be champions locally and also champions on our end. on both sides. And you have to keep at it. These are long-term kind of things. So we're back in Merida thinking about doing more things. And finally, think about utilizing technology. We know a lot more about technology in the last 2 years with COVID, with remote kind of technology and those sorts of things. And I'm really out of time, so I'm going to stop right there. And let me just say that it is always my honor to be able to talk to people in other kinds of settings like this. And in better times, in non-COVID times, I would actually be there to talk to you. So I'll leave it at that and just say thank you.
Thank you so much, Dr. Jade. It was very insightful presentation. Indeed, social, mental, and spiritual health is as important as physical health, and global interventions are mandatorily required to address human dysfunction. Now we will move towards presentations. The number of papers presented in this session are 8. 4 are going to be presented virtually in room B on Zoom and physically in lecture hall 1 at NUS Business School, and rest of 4 will be presented virtually in room C and physically in lecture hall 2 at NBS. So depending on interest, audience can choose which session to join. So those who have presentations in room C, they may go there. I would like to call Ms. Anam, affiliated with NUS, to present her paper. Her paper is titled Cultural Adaptations of Mindfulness-Based Intervention for Reducing Stress. Ms. Anam, you have 15 minutes, and after 10 minutes, we will give you a reminder. Thank you so much. Over to you.
Okay, thank you so much. So I'm going to share my screen here.
Yes, sure.
Please let me know if you can see my screen.
We can see your screen. And you are audible. Please start your presentation.
Thank you so much for the confirmation. Okay, so I'm currently a doctoral candidate at Department of Behavioral Sciences, NUST, and the research that I'm going to be presenting over here today is part of a bigger PhD project. So this is the cultural adaptation of mindfulness-based intervention for reducing stress and enhancing psychological well-being in university students.
Ms. And I'm sorry to interrupt you. If you will put on slide share, then it will be more visible.
Oh, yes. Now is it okay?
Thank you so much. Yes.
Okay, thank you for reminding me. So, okay, so continuing with the keynote, the mental health of young adults is becoming a global concern, and different surveys have been conducted worldwide, indicating that individuals above 18 years are facing mental health problems. And university life in itself is a transitional stage, given the mental health of young adults, and they have to address several challenges here. The stress prevailing in students has negative consequences on their educational performance, their achievement, occupational preparedness, and other domains as well, including emotional regulation, attention regulation, relationships, and social interaction. And now mindfulness-based, there are several interventions that have addressed different issues for university students. Mindfulness-based interventions have shown benefits for stress reduction, personal growth, psychological well-being, resilience, as well as academic performance. And it is imperative for the interventions when they are when they have been developed in one particular culture, that when they are used in another culture, there needs to be a systematic adaptation in order for it to become effective and have its impact on the said population. So the Medical Research Council guidelines, which have recently been updated in 2021, along with the heuristic framework for cultural adaptation of interventions, which is another framework, it has been embedded within the MRC framework to bring methodological rigor to the adaptation process. And these both have been used in health interventions as well as in psychological interventions as well. Okay. So coming specifically to Pakistan, in developing countries like Pakistan, the challenges faced by university students include academic as well as psychosocial concerns, like, for example, high parental expectations, frequency of exams, sleeping difficulties, struggle with identity, loneliness, worrying about the future and performance. This is just one research that I have quoted. There are several which address other domains as well. Now,
sorry to interrupt you, Ms. Anam. If you can speak little louder, because audience has problem in hearing your voice. So kindly speak little louder.
Is it okay now?
Yes, thank you for your cooperation. Thank you so much.
Okay, thank you. So now in low middle income countries, including Pakistan, when we talk about the statistics, they are disturbing, with young adults comprising more than half the total population. And many of them, almost 12.7%, are enrolled in universities, which further emphasizes the need for psychological interventions within educational institutions. And the mental health contributes to the economic burden, which, combined with scarce mental health resources, is a serious issue in low middle income countries. So therefore, there is a need for preventive interventions which are needed to emphasize stigma-free mental health interventions. Now, moving forward from there, the evidence base for mindfulness-based interventions has reached a level of significance in the West, where it has now been included at policy level to become part of curriculum for students. In some of the universities, there are centers as well. So MBIs have been shown to have benefits beyond temporary relief from present psychological problems, and they have been used in different cultures, indicating their implementation benefits for young adults of Pakistan and cultures that are similar to Pakistan. What is important here and is the need is systematic adaptation procedures which bring transparency to the translational research process, bringing science and practice together, and increases the impact of indigenous interventions for the target population. So the objectives for this research are to culturally adapt finding peace in a frantic world for university students in Pakistan. This is an intervention developed by Williams and Penman in 2011, and it incorporates the principles both from MBSR and MBCT. So to evaluate, the next objective is to evaluate the appropriateness of outcome measures to be used in future trials for assessing stress, psychological well-being, and mindfulness levels in university students in Pakistan. So in order to address these objectives, the methodology that has been utilized here is comprised of 2 phases. The first phase was for pilot testing of the outcome measures so that they can be used in the next phase and the future trials as well. And the second phase was the cultural adaptation of finding peace in a frantic world for university students in Pakistan. So for the first phase, I've shown the results over here. The sample was of 30 university students. And as mentioned earlier, the outcome measures were mindfulness, psychological well-being, and reduction in stress. And these are the instruments which were previously translated and adapted by different researchers. And they were used in this research to find out that whether they were reliable for this particular target population. And as you can see that all of the instruments show strong internal consistency, that is high reliability. Okay, now moving to the second phase, which was the main part of this research, that was the cultural adaptation of finding peace in frantic world. It incorporates the first phase, it actually depicts the first phase of the MRC guidelines, that is the adaptation or the development of an intervention. And as you can see that the first line of the blocks, it shows the flow of the steps that were followed in the adaptation. So the first, and this is the heuristic framework. These steps are the heuristic framework model. So the first step was information gathering, and the systematic review as guided by the MRC guideline is required when for the development or the adaptation of any intervention in a new culture. So the information was taken from there, as well as there were 3 areas from where the information was gathered in order to identify that which areas require adaptation and what needs to be adapted and how is it going to be adapted. So for that, firstly, an adaptation committee was formulated, which comprised of the researcher, a mindfulness practitioner, research methods expert, and clinical psychologist. And the method that they went forward was through committee meetings, regular committee meetings. Then there were local sources, that is the intervention, Finding Peace in a Frantic World, was test run of an intervention was done on 6 students. That is, this is a participatory research model. So the intervention was taken to the students and their feedback was taken. the changes that they suggested or the things that they found difficult were addressed. Then there were the intervention was also given to a teacher and community intervention experts. And 10 meetings were held with the students, 6 meetings with the teacher, and community intervention experts, 8 meetings were held with them. Then there were international and national collaborators, so which included mindfulness researchers, practitioners, and developers. They were collaborated with through emails and video conferencing, once again discussing about the intervention so as to keep the core essence of the intervention in place. And then preliminary, after this basic information was gathered, the preliminary adaptation design was formulated, which was done through Urdu translation was done, and along with adaptation, certain changes were made in the content. And the translation was done through 4 independent bilingual translators. One was a professional translator, one was a teacher plus having psychology background, and 2 psychologists. So the different materials that were translated, which comprise the intervention, are the reading material, which is to be given to the students during the intervention. Then there is a workbook in which there are worksheets that students are going to be filling as they practice their mindfulness activities and practices. And there are audio recordings of the guided meditations. And then once this adaptation was done, it was reviewed by 4 reviewers. And once this material form of this adaptation was compiled, it was preliminary tested on 8 university students. It was, since it was done in the pandemic time, so it was an online intervention. Delivery was done. There was a feedback was taken from the students, and pre-post assessment changes were monitored through the instruments mentioned earlier, measuring mindfulness, stress, psychological well-being levels, and the facilitator's reflections were also incorporated. And then finally, the refined form of the adapted intervention was finalized.
Ms. Anam, you have 5 minutes left.
Okay, thank you. Okay, so this slide over here, it summarizes what changes were made. So based on the dimensions of adaptations highlighted in the heuristic framework by Merida and Castro. So the type of adaptations were 2, that is in the content, which includes the reading material and the audio meditations and the form. So reading material it is a complete book. So only the weekly chapters, the 8 weekly chapters were used. And the audio transcriptions within the chapters, they were removed so as to reduce the number of pages. And there was repetitive content, which was also reduced. The form was converted to online delivery with 8 weekly sessions, and it was group-based. Now, coming to the content adaptations, they were in 4 dimensions. That is cognitive information, which included a translation into the language, cultural relevance of expressions, names, examples that were used. The language was made much easier, and single word concepts were explained. For example, acceptance, awareness, allowing self. And
your voice is being distorted.
Is it okay now?
Yes, it is.
Okay. So, and one thing was added over here, that an introductory audio recording was prepared to give an overview or an orientation towards the intervention. Then the second dimension was effective motivational, in which the rationale for different expressions was given, that why these things need to be expressed or practiced. And then the value conflicting examples were changed, and student relatable examples from their academic and social life were included. Environmentally, the time of the sessions was reduced to 60 minutes, and email reminders along with poems, relevant poems and quotes which were based on that week's theme. And the last session, they were also included. Okay, these are the preliminary results from the outcome measures. And as you can see that there is a mean difference in the before and after results in all of the 3 domains. That is increase in mindfulness and psychological well-being, and potential reduce in the distress or stress. Okay, now coming to the conclusions, the feedback from participants and stakeholders on the course content indicated universality in the core principles of the components. Adaptations in the 3 dimensions were made. The systematic adaptation process provides the groundwork for future pilot and definitive RCTs to explore the feasibility and effectiveness of adaptive mindfulness intervention for university students in Pakistan. The transparent approach towards adaptation procedures can serve as a clear guideline for other researchers culturally adapting interventions across the globe. And finally, the pilot testing provides cultural relevance of the outcome measures for university students in local context. Thank you. That's it from my side. Any questions?
Okay, if there is no question, then we move forward. Thank you, Ms. Anam. The next presenter is Ms. Hajra. She is affiliated with NAST. Her title of presentation is Psychosocial Determinants of Cognitive Function Among Older Adults. Over to you, Ms. Hajra.
Yes, assalamualaikum everyone. Just give me a second. I'm just pressing on my screen. I hope you can you see my screen, everyone? Okay, is my screen visible now?
Yes, please put it on slide share.
Yeah.
Start presenting.
Yeah. Give me a second. Okay, so my name is Hajra Akbar. My name is Hajra Akbar, and I'm a student of MS Clinical Psychology at NAST. So basically, I am the first author and the co-author of this systematic review is Dr. Samara Masood Hassan. The topic of my systematic review is psychosocial determinants of cognitive functioning among older adults. Somewhere here. Okay, basically, first of all, I would like to tell you about what cognitive functioning is. Cognitive functioning is defined as a variety of mental abilities, which includes a lot of domains such as memory, perception, learning, thinking, judgment, etc. According to the statistics, people aged between 60 and above, they make up 13% of the world's population, and 35.6 million older adults were suffering from cognitive dysfunctions in 2010, which is still expected to increase, and this is a paramount it's noticeable digits, I think. So that is why it's very critical to study cognitive functioning according to these statistics. The reason I've chosen this subject is because intact cognitive functioning is a pertinent indicator of functional abilities, life quality, and independence, successful aging. Whereas if there is any distortion or any sort of disturbance in cognitive abilities or functioning, it leads to a lot of functional as well as behavioral impairments. And in general, all of this imposes a burden on patient, caregiver, and the economy as a whole. And poor cognitive functioning, they lead to a lot of mental cognitive disorders such as mild cognitive impairment, dementia, Alzheimer's, Parkinson's, and etc. Okay. Moving on to the rationale, as I already mentioned, that cognitive functioning is a significant determinant of successful aging. Despite this fact, there are not sufficient amount of systematic reviews on this domain is seen. And previous systematic reviews, they're primarily examining biological determinants or social protective factors or treatment and assessment for cognitive functioning as well. However, the psychosocial determinants of cognitive functioning older age is yet overlooked. Objectives of this research. There are three objectives. First of all, to summarize the evidence for psychosocial variables associated with cognitive functioning in older adults, to identify the underlying factors which affect this association between psychosocial determinant and cognitive functioning, to find out the theoretical and literature gaps in the work conducted on this subject previously. This is the methodology. I will just, because it's the larger area, so I will just go through it. First of all, selection criteria for this study, for the studies, here is the selection criteria. First of all, definitely the outcome variable must be cognitive functioning. Age should be, the sample age should be 60 and above. Articles should be peer review, text should be written in English, and articles published in 2000 to 2020, and LGBT samples were excluded. And the measures should be, cognitive functioning measures should be used in the studies. And then search strategy information the sources. The literature was conducted between November 2020 to January 2021, and the primary databases were Web of Science, PubMed, and Science Direct. Keywords used were cognitive functioning, global cognitive functioning, cognitive impairment, age-related cognitive decline, etc. And again, this was the exclusion criteria as well. For example, the articles which were excluded, for example, if it wasn't in English language, or the year was not according to what was defined in the selection criteria. Selection process for included studies was that after screening the articles which did not meet the inclusion criteria were excluded. Articles with outcome variable other than cognitive functioning and the animals based studies were also included. Ryan software was used for excluding the duplicate cases, and then STOVE and sign checklist was used to assess the quality and internal validity. Then data analysis, and then they were definitely marked with 3+, and this scoring was given for each of the studies included. Data analysis and synthesis. After the articles were extracted according to the inclusion criteria, following information from each of them was extracted, which was year of publication, methodology, results, discussion, sample, and population. So this is the flow chart. When from different, like, first of all, the data studies were extracted from 3 different databases, and then duplicates were removed, and then the remaining, they were screened on the basis of title, and then some were excluded. Again, the other the remaining were screened on the basis of abstract, and then finally on the basis of the full text. And at the end, the 20 studies were remained. I had 20 studies for the analysis for this systematic review. And the research questions were defined and stated, and how accurate the research procedures were, and are the results sufficiently linked to the objectives or not. Then these are the characteristics of the studies included in the systematic review. It was based on the methodologies which were used, sample of the population. Could you please tell me that, because I don't have enough time, so should I go into the details of each of this?
I think sharing the outcomes would be more important.
Okay, well, yeah, because this is
We
just
would have access to your slides, so
okay.
I think sharing the outcomes.
Okay, then I think I should go to that part, because I'll just briefly tell which were the characteristics of the studies. One of them was based on methodology, which were used in all the studies, the sample and population, and then on the basis of gender, the measures which were used. And then because there were, I divided whole thing into 3 different factors as well, so like risk factor and protective factor, and one of them was risk and protective factor. So these were the characteristics, and final results were these, where I got 20 studies, and from the overall final sample, I had 5 studies from PubMed, 12 studies from Web of Science, and 3 from Science Direct. These are the different categories which I divided. One of them was demographic determinants, social determinants, and psychosocial, psychological determinants. These are the subcategories of 3 major categories, which were demographic determinants, psychological, and social. So here, there are just the subcategories which I'm just going to present. Okay, so in psychosocial determinants, psychosocial determinants was divided into 2 categories, which was, one of them was affective disorders, which include depression, anxiety, bipolar, and the other was the personality traits, which included neuroticism and conscientiousness, extroversion and openness. I will go through into these in the next part discussion. So I'm just overviewing it. Then there is social determinants, which included the social participation and engagement. And then there is demographic determinants, which includes age, education, smoking, weight, etc. So and all these have, I will also tell that the associations between them in the discussion part. Okay, so this is the demographic determinants section. Basically, the first point is that that cognitive functioning is basically decreased with increased age. The possible reasons for that could be because at the later age, a lot of people, they go into sedentary lifestyle, which decreases their social engagement, and social engagement, it requires a lot of complex cognitive abilities and which isn't used due to their sedentary lifestyle. And then fewer cognitive resources are left there, and they don't have a lot of cognitive reserve at the later age because of their sedentary lifestyle. Coming to the next point, education, or little or no education, it is also the association between education and cognitive functioning is that with low or little education, cognitive functioning also decreases, because education basically lifetime education, it enhances lifetime stimulation, and it is also argued that low or little education, it reduces the intellectual reserve to the level that if there is any like minor pathology, it leads to cognitive impairment. Use it or lose it hypothesis also supports this association, which says that one can maintain their cognitive functioning by engaging into the cognitively demanding activities, and if one if one is not involved in such activities, it leaves a detrimental effect on their cognitive functioning. Then ethnicity is another determinant. For example, which shows that, for example, if someone is not from a minority group, and in a place where majority is like with the people, majority people are with some other ethnicity, so it will enhance the level of stress, and different studies also show that stress increases. It's one of the major risk factor for cognitive dysfunctions. Smoking, it basically smoking is associated with cognitive functioning in a way that if one is more indulged in smoking, cognitive functioning will reduce. Why? Because it has a lot of impact on respiratory system, and there are a lot of medical interruptions, biological interruptions as well. And if we understand a person with such sort of breathing problem and all of this stuff, it will definitely hinder his attention, concentration, planning, and all the abilities. So that is why it is one of the possible explanation for this association. Next is overweight, or we can say obesity. It increases the risk of disruption in cognitive functioning as well, because when there is high level of perceived stress and this attitude of the society for people towards people who are overweight or obese, so they will have a lot of stress. And again, as I mentioned before, stress and depression, they are one of the major we can say major risk factor for cognitive dysfunctions. Moving on to the other, alcohol consumption. Although it is seen that alcohol consumption is beneficial for health because it reduces, it helps in relaxation. However, there are negative health consequences as well, such as reduced absenteeism and low reliability and reduced job, which leads to, hindering the utilization of cognitive abilities. And again, if for a longer time, if according to use it or lose it hypothesis, if we abstain ourselves from using our cognitive abilities, they get rusted. Then moving towards psychosocial, the psychological determinants, one of them is psychosocial disorder, which includes depression, anxiety, and bipolar, etc. And all of these have inverse relationship, that if these affective disorders are increased, the cognitive function reduces. People who are like more anxious, they are more vulnerable to stress, and which leaves adverse effect on their cognitions. Similarly, they avoid social participation, and due to which they don't get a chance to use their complex abilities, and they get rusted again. And again, if you talk about fewer leisure activities, they include if there are like fewer leisure activities, depression level will be increased, and people with such depression and specifically people with depression, we've seen that their interest in activities reduced, and again they are not able to use their complex cognitive abilities. Personality traits. High neuroticism and low conscientiousness is related to risk factor. It's one of the risk factor for cognitive functioning. People who are like with high neuroticism, they are more prone to anxiety and vulnerable, and they're vulnerable to stress, which significantly impacts their cognitive domains. And then if you talk about high agreeableness and extroversion, these are the protective factors, because yes, definitely people who are extrovert, they are more involved in such sort of activities, and their cognitive abilities remain in use till the later age. Last category is social determinants.
Ms. Hajra, your
Which
time is
first
over.
of all,
Kindly wrap up.
there is retirement. Yes. Okay,
Kindly
I'm so sorry.
wrap up.
Just okay. This is the okay.
Thank you.
Thank you for the reminder. So okay, can I just complete it? This is the last slide.
Yes, you may.
Okay, thank you. So first of all, there is retirement, that people who are who get retirement at early age, they don't get to use their cognitive abilities till the later age, and again their cognitive functioning is reduced. Similarly, social isolation, if you're not interacting with people, because social interaction is an effortful task and require frequent as well as efficient use of complex cognitive processes, and if it isn't in play, so definitely cognitive functioning will reduce. Lastly, social participation is also associated with social isolation. Then I'm just giving the summary of this. Most of the studies in this systematic review, there were longitudinal studies which give into the insight of the mechanism that how psychosocial determinants may affect one's cognitive functioning. And then most of the studies were based, the female ratio was higher in their studies, which shows that females have more they have a longer lifespan, or either we can say that this gender is more at risk for cognitive dysfunctioning. And lastly, most of the studies were conducted in China or Japan. Again, the reason would be possibly it could be active life expectancy or increased longevity in China and Japan. So that is why. So these are just the strengths and limitations, strengths of the systematic review, that the studies were conducted, divided into 3 different categories, which gives a better understanding of the determinants. And current review is based on data gathered from more than one database, which could have contributed into the richness of evidence, and adequate summaries are provided. Our research does not assume that selected keywords should be included in the title or abstract. Instead, we also focused on similar terms other than the selected keywords. Strobe and sign checklist was used, and limitation is that limitations are that although brief criteria for the assessment of studies were outlined, but the operational definitions weren't given. So future recommendation is that operational definitions must be given for each. And most of the studies included MMSE, which is objective, which is a screening tool, and it lacks the sensitivity to early signs of cognitive decline. And implications is that this review provides a concise summary of current literature about the psychosocial determinants of cognitive dysfunctions. Therefore, it would aid clinicians to understand the origin of cognitive decline in absence of any origin cause as well. This is just a conclusion, and thank you so much. I'm so sorry I took a lot of time, so sorry.
Thank you.
If you
so
have
much,
any questions, I'm up for questions.
Yes, audience is invited to have question answer session.
Any questions?
So we would have time to do a discussion in the end, right?
Yes.
Yeah. Okay.
If there is no question from audience, we will move towards the next presentation, which is being presented by Ms. Sumbal Gilani. She is affiliated with NUST, and the title of presentation is Integrating Mental Health Services in Existing Healthcare System in Pakistan, a Public Mental Health Approach. Ms. Sumbal Gilani, over to you. Please share your slides.
Okay, Assalamu alaikum. Thank you so much. Can you see my slides?
Yes, we can see your slides. Please put it on slide share and start your presentation.
Yeah. Okay. Assalamu alaikum, everyone, and thank you so much for giving me an opportunity to present at this platform. Because being a graduate from NUST and presenting here with my peers, my teachers, and my juniors is a great honor. So I'm glad to be here. I'll be presenting a research here today, an implementation research that is really very close to my heart, because this is something which was never heard of, never expected, never planned in Pakistan. And fortunately, we had the opportunity to do this here. So the topic of my presentation here is integrating mental health services in existing healthcare system in Pakistan. A public mental health approach was taken for this. And my co-author for this research is Dr. Saeed Irfan Ali Shah. He is Deputy Director Public Health in Health Department KP and currently at the University of Amherst for his studies. Before I start on with explaining what we did and how the research was made, I would just want to give you a little bit of an introduction of where this work was conceived and how it was basically started. So back in 2014, when the terrible attack on the Army Public School Peshawar happened, that's the time when the key policymakers, decision makers, and people in health sat down and realized that the province direly lacked mental health services. There were a few psychiatrists who were practicing at tertiary care hospitals and the big hospitals in the city, but again, they could not reach out to the public at the primary level or at the ground community level. And the work of psychologists was minimized to just support the psychiatrist in their work. And when there was so much trauma in the community, they realized that there was no one to do the trauma work, to help people, to provide counseling. So the Department of Health, with the support of UNICEF, started a small-scale project in which they employed some psychologists, and they started doing trauma work, basic counseling with the community, with the families of bereaved, basically. But the response to that project was so good that in 2018, 17 and 18, they hired a team. I was fortunately a part of that, and they wanted to structure the project into something that could be piloted as a study and later on replicated to the other parts of the country as well. So I'll just skip the data because in the interest of time. So the rationale behind this study was basically to develop a sustainable model of mental health services for the population of Khyber Pakhtunkhwa through the provision of standard psychological interventions at all levels of healthcare. And the aim was to reduce the stigma, to improve social integration, and to enhance human resource for mental health. Because like in the opening remarks, Dr. Jade talked a lot about sustainability. And I think this project was purely grounded in that because no one wanted to do this work for 3 years and then wrap it up and leave, particularly after creating a lot of like the demand in the community as well. While designing the project, we took up a lot of help or a lot of data from WHO models that were used all over the world, that were particularly piloted in third world countries. But the theoretical perspective that we employed behind using or adapting them to Pakistan was the knowledge to action framework. Because evidence-based practices was what we wanted for people, and they had to be contextualized. So vigilant review and constant monitoring, constant feedback, then changing the plan, then going out again, that was the approach that we were constantly using. And within this action cycle, the problem identification was the crucial part. So that's why we had to constantly monitor and see what was coming out of it. The research question was how to improve access to mental health services for a lower middle income country with limited resources. That was Pakistan for us. And for the methodology, like I said, it was an implementation research paradigm. Data was collected. This data that I'm particularly talking about is for the end line and the baseline that was conducted for this project. A mixed method approach was used in which qualitative as well as quantitative tools were used, and mostly for the services part, we used all the tools from WHO that helped us assess what was present there, what was enhanced later on. And for the community, some surveys and a lot of FDGs were also used. And the intervention was basically the implementation of a comprehensive mental health services plan that was called as the CMHSP. It was developed and implemented in the district Peshawar for 3 years, and then an endline was conducted, and later on we had some very good outcomes of it that I'll be talking about later. So what was CMHSP? The Comprehensive Mental Health Services Plan, or the CMHSP, was basically the integration of standardized or evidence-based mental health services at all healthcare levels within the existing health system. In Pakistan, healthcare system is divided into 3 basic parts. There's primary, then there's secondary, and then there's tertiary. But if we look at the WHO pyramid for health services, we also see a self-care part and then an informal community care that comes below the primary healthcare level. So we try to target these as well. So the interventions were spanned over 5 healthcare tiers, basically. What we did at the self-care level was that an extensive amount of IC material was developed that was disseminated through all the kind of medias that the public was excessively using. For that, a PSA was conducted before the rollout and development of this IC material, because the aim was to help people understand what mental health is, how they can watch out for signs, and what they can do about it if they notice anything in themselves. At the informal community care, going by the WHO motive of using non-specialized mental health workers in the provision of mental health, LHWs, that is the lady health workers, and teachers at government school levels were trained. For these particular modules were developed to help the teachers to screen the children, to ensure that they are mentally healthy, to ensure that the environment is good for children and they're playing healthy. And then the LHWs were trained on a module that was adapted from the MHCAP module of WHO. It was translated into Urdu because considering the capacity of LHWs, and it was translated in a way or adapted in a way that the psychiatric services were of course removed, and basic counseling, more and more concepts of basic counseling were introduced into it. Then the primary healthcare level, medical officers at all the primary healthcare units within District Peshawar were trained. So they were based in basic health units, BHUs, civil dispensaries, CDs, and RHCs, that is the rural health centers. So we made sure that all of them in District Peshawar were trained on the MHCAP module, basically. Then on the secondary healthcare level, we had 10 hospitals within Peshawar. The secondary care hospitals usually do not have a psychiatrist nor a psychologist. So what we did was that psychosocial family counseling centers were established in these hospitals, where 3 psychologists were placed. One was a senior psychologist and 2 were the supporting psychologists. And what they would do is that they would provide therapeutic as well as counseling services within those centers. And finally, at the tertiary care level, like I said in the beginning, that we already had psychiatrists working there. We already had psychiatry units and departments working there. So they were made a part of it. And all of these 5 healthcare tiers were connected via a robust referral mechanism. So at every level, when these trained people would receive a person who has mental health concerns, if they can manage them within their capacity, fine. Otherwise, they knew where to refer the person. So a referral guideline was made, and it was disseminated to all of these people who were trained. And this was remarkable because it took us almost 1.5 years to train all of these people. But when they got trained, it was like you have trained an entire what do I say? And the current existing staff of the health department. It seemed like that, and it was remarkable for us, I guess. And at the same time, another aspect of this plan was that the community and policy makers were engaged in advocacy. So an MHPSS strategy for the province was also developed, which included all of these services, but of course the plan was sustainability. The policy makers, the decision makers, we wanted them to take the plan forward once UNICEF backs off with their fund. So that was also another part of it that was going on simultaneously within this project. So if I immediately jump to what the end line showed us was that the prevalence of these primary disorders, that is depression, anxiety, trauma, and stress-related disorders, as well as somatic disorders, was reduced by around 25% within the district Peshawar. Then the service-seeking behavior was increased by about 90%. The at-risk and vulnerable population was identified as children, adolescent, women, and first responders. That's what helped us in forming the strategy and to planning the further steps. And the protective factors were identified as helping behavior, community, religion, awareness, trained healthcare workers, and availability of mental health services. Briefly presented here are some of the results of the end-line, and I would particularly want to focus on the very last slide, that is trends in service-seeking behavior. It was amazing that they started in 2017, and so many, like the trend was not as developed as we had it in 2020. And I haven't quoted the data from 2021 or 2022, but it has been increasing amazingly ever since. So we knew that we had
5 minutes.
Okay, I'm almost at the end. So we knew that we had created a niche. We were making people think about mental health. We were tackling stigma, and now people were open. So the CMHSP, the Comprehensive Mental Health Services Plan, was doing what it was made to do. If I talk about implications and limitations, there were a lot of bottlenecks. There were a lot of blockages around which we had to maneuver. First of all, monitoring and evaluation. Like I said, the human resource was huge. We trained a lot of people. So monitoring all of them was a struggle. There were around 319 doctors trained. There were around 1,100 LHWs trained. And then there were 900 plus teachers trained. So it was a struggle to monitor and evaluate them. Then the motivation of workforce of these trained people was also a struggle. To get the health department on board, to get them to convince these people to actually do what they were trained to do, that was a struggle. Then the project was big. We needed funds, and it was a struggle constantly to go back to UNICEF. They were kind and generous enough to give us the fund whenever we needed it, but it was a struggle. And the same model could easily be replicated because it has been properly documented, and I think that could have some very good outcomes for the entire country. And what we gained out of it, the biggest success that I think this research or this study basically had, was that currently the project has been taken over by the KP government, and now it has been expanded to the entire province. So it was sustainable, it is what people needed, it was acceptable, accessible to people. And as a conclusion, this was the first of its kind study, very comprehensive, very thorough. It was highly effective in engaging the district level administration in mental health services. People who would not acknowledge that mental health exists actually helped us build this. And then it was highly effective in evidence-based approach of system strengthening. Whatever was done, whoever was trained was right there in the system, picked up from the system and left there to serve them. So that's all about my study. If you have questions, you're more than welcome.
Thank you so much, Ms. Sumbul. Audience is invited to have question answer session. Okay, so if there is no question, we will move forward towards next presentation, which will be given by Dr. Sehrunisa. She is affiliated with NAST, and the topic of presentation is Women's Reproductive Health, Coping with Infertility. Over to you, Dr. Seher.
So can you see my presentation?
Yes, we can see your screen. Please enlarge it and put it on SlideShare.
Okay. Is it clear now?
Yes, we can see your slides.
Okay. Good afternoon to everyone, and thank you very much for all of you for being here. I'm very glad that in the beginning we got a chance to hear a wonderful presentation by Dr. Megan, and it was helpful to validate my experiences and my work. And then now we got a wonderful presentation from Ms. Sumbul, and it was again very enlightenment, as well as very encouraging to see that how much good work is being done in Pakistan, alhamdulillah. So I would like to start my presentation. It's about the quality of life and coping mechanisms in women with infertility. It's relatively easy to talk about the women's experiences of infertility and the stress associated with it. But certainly it is very hard to go through such experience. The status of being an infertile woman, actually, those share many common outcomes in form of a poor physical health and poor mental health, but at the same time, it is a very unique experience for each woman. Why and how this experience becomes unique for each woman is mainly due to the social circumstances. And I think Dr. Megan also talked about these social circumstances. The varying nature and intensity of the social pressures and the social stigmas faced by the women much determine their infertility difficulties. I, as a researcher, always keen to study about topics related to women's mental health, I will try to remain objective as much needed, but at the same time, being a woman who herself has gone through such experience, it is an opportunity for me to share the deeper insight about the various factors associated with the infertility experience and how do women cope with it. I'm hopeful that sharing this understanding at this platform will help us to discuss and come up with better intervention and prevention measures. So let's first talk about some of the facts and figures. Infertility has significantly contributed to the global burden of disease in the past 2 decades. The rates of primary and secondary infertility among women of age between 20 to 44 years are 1.9% and 10.5% respectively. And this has been increased according to the latest estimates. The study mentioned that 15% of the couples globally at increased risk of poor reproductive and mental health due to infertility and the invasive infertility treatment. And I couldn't ignore mentioning about this incident, which happened just yesterday, and it has been reported in the today's newspapers. You can see this screenshot is from the Dawn, where the Dawn is reporting that the Peshawar police on Tuesday took notice after a woman turned up at a hospital with a nail hammered into her head on the directions of a faith healer in order to give birth to a baby boy. So this latest news, which is just the incident just happened yesterday, can help us to understand the irony of the situation. Though infertility is a couple issue, however, women are known to bear the blame and burden of difficulties associated with infertility. Previous research has shown that the increased vulnerability of the women to experience poor quality of life due to infertility. Women suffering from infertility develop symptoms of depression, anxiety, feelings of inferiority, inadequacy. Sometimes there are complications in the interpersonal relationships. Then there are social and cultural as well as religious factors just mentioned profoundly influence women's experiences of infertility during their reproductive age. And it ultimately has an impact on their various domains of the quality of life. Women, particularly in the developing countries and the traditional societies like Pakistan, India, and other few countries in the African region, they face reduced social status due to infertility, and they are at increased risk to face partner violence. This is all in the light of the previous research. The deep-rooted cultural and social practices raises in them questions. The women themselves question, what is their own worth? And these women have been shown to have a low self-acceptance, and they have self-compassion actually relates with being warm and being understanding towards oneself when we suffer or when we feel pain. So rather ignoring our pain, attending to it, and it becomes difficult for women with infertility difficulties. And ultimately, it significantly influences their emotional health and their well-being. Besides, just not only the mental health reproductive services are meager, but there are disparities, just like Sumbal mentioned about the disparities in access to the mental health care services, but there are also disparities in access to the reproductive health care services. And this disparity increases the risk of the women to face difficulties in seeking right treatments, right infertility treatments. So knowing that infertility is a major stressful event for women, so it is relevant now to see that how a women are coping with these experiences. The psychological literature explains coping as thoughts and the behaviors which are used by individuals to manage the internal and the external demands of the situation that are perceived as stressful. However, the psychological literature also explains that the people are different. There are individual differences in terms of their reactions, in terms of their coping. And the basis of these differences are sometimes due to personality and sometimes due to childhood developmental experiences and sometimes due to culture. However, it is very important to note that the coping styles are very important mechanisms. They are considered as a gateway for interventions due to their ability to activate various cognitive and behavioral processes. Previous research has shown that the women who experience greater levels of, usually the women are more likely to experience this stress because they are carrying the more burden. And according to the statistics, which are very recent, 30 to 40% of the women with infertility difficulties meet the diagnostic criteria for psychiatric disorders, including stress, dysthymia, and major depressive disorder. And furthermore, these women are also more likely to score high on self-judgment, and they score low on self-compassion and self-esteem. In another study, and this study was although from a Western country, when the women were aware that the reason of infertility is linked to the female reproductive health problems, they are more likely to use venting and self-blame. And self-blame adds to the distress due to infertility, and it affects women's mental health. Knowing all, in the light of all this literature, and as I mentioned in the beginning, that the infertility experience is still a unique experience for each woman, and it is primarily due to the social circumstances. So this study aimed at assessing the relationship between the social domain of the quality of life of the women and the coping strategies employed by them to deal with these challenges. The study is very simple. It's a descriptive study, and I collected the data from 350 women who were undergoing infertility treatments in reproductive healthcare centers in Quetta. Why Quetta? Certainly, the Quetta is a province which is known to have the traditional and the cultural dominance for many years, and the women have more likely to expect it to stay in their traditional roles. Standardized psychological tools were administered for TQOL and hope inventory, and this study was approved by the Ethical Review Committee of School of Social Sciences and Humanities. The first results which I would like to discuss are about the social quality of life. What is social quality of life? According to this tool, although you can define it in other ways, but I'm now limiting this definition according to this tool. The social domain of the quality of the life includes three dimensions or three aspects. The one is the social pressure, the other is the social isolation, and the third is the social support. Some of the notable figures are related to the social pressure, and we can see that 79% of the women reported that they feel very much pressure on them from the society to have a child. And a similar percentage felt that they have lower social status because of this condition. So this is really an indicator of how much social pressure is being faced by these women. Regarding the social isolation, we found that 38% of the women, they experienced it, and they feel anxious of going into the social gatherings. And also the similar percentage, they felt that they experience social isolation because of these infertility problems. There are some contradictory findings related to the social support. It was encouraging to see that 50% of the women reported that they were satisfied with the support they get from the friends and the family. But then when we look at another item, where 15% of the women said they think that their family never understand their problems to which they are going, and 37% mentioned that they seldom understand. So it seems that the women themselves are having some kind of psychological struggle where they wanted to appreciate the support they get from their family, but at the same time, they are going through some experience of loneliness or social isolation due to these difficulties. So in the traditional societies, there is some evidence that our findings can be validated with findings from some other regions. For example, this was one of the study which was conducted in African region, and they found that almost 56% of the women reported social exclusion, and 41% reported verbal and physical abuse, and 3% even reported the marriage breakdown. Ms. Rita, who is one of the consultants working in the fertility centers, he reported that the culture demands that a woman, to be socially acceptable, she should have at least one biological child. So all these background or all these statistics are actually really showing that how much social pressure is experienced by women who are going through infertility. But of course, we can also observe that the women are surviving and dealing with it. So it must be because of some of the coping mechanisms adopted by women. And the aim was to see how these coping mechanisms and this social domain of the quality of life are connected. Although there are many ways people can use to adapt, however, according to our tool, we focused on these three main methods. The first is emotion-focused coping, avoidance coping, which is also considered as dysfunctional coping, and the problem-focused coping.
Dr. Seher,
Within emotion-focused coping, we found that the women were more likely to cope through religious coping. And if the religious coping is just focusing upon direct prayer and asking from the God, that is safe. But just yesterday, the incident which we observed where the nail was hammered on the head of the woman just in an attempt to give birth to a baby boy. So this type of coping can be very dangerous, honestly speaking. The positive reframing was also adopted by women who were likely to adopt emotion-focused coping. The title of these coping styles are self-explanatory, however, because I assume that most of the people are from the psychology or mental health background, but we can also discuss if needed. The avoidance coping, within the avoidance coping, we found that the venting, self-blame, and denial were the most dominant methods. And within problem-focused coping, the use of instrumental support was seen. However, we were more interested in seeing that how these coping styles associate with the social domains of the quality of life. So what we found, I think my screen is showing here. So what we found that the social pressure significantly negatively associate with acceptance. Acceptance means that where the women are able to accept their status of this infertility and not just keep on struggling and struggling with their self-identity or self-esteem. So we can see that the women who were facing such extreme amount of social pressure, they were less likely to have this acceptance. And this may impact their mental health and emotional health. Also, these women are more likely to cope through religious coping, and which is again can be helpful if it's in different form. Otherwise, it can actually make them more vulnerable. Then the social isolation was associated with avoidance coping and behavioral disengagement. So the women were either denying or either they were avoiding because of the social isolation. And this is again has a detrimental impact on their mental health and well-being. However, social support overall seems to have positive impact in terms of that it helps women to use the positive reframing. And the positive reframing is about coming out of those difficulties in a positive way and and using it as a growth experience, rather struggling with that experience. And these women were also more likely to plan in terms of their infertility treatments or the future life And also these women were more able to use the instrumental support, like the practical help, which can let them get out of this situation rather staying with that and continue with suffering. So overall, our findings suggest that the social domain of the quality of life significantly associate with women's coping and their infertility. And if we can focus upon the social enhancement of the social aspect of the quality of life, it can actually help women to experience infertility in a different way. It will not become a trauma for them, but it will become just one aspect of life that they have. The recommendations, just as in the beginning, Dr. Megan and before Ms. Sumbal has suggested, that there need to have an integrated and holistic approach. And we need to focus upon the community-based interventions. So if we are going to demystify the causes related to infertility, we can find out the more appropriate ways to handle its repercussions. This is a screenshot from one of the program which is which is in India, where the community-based intervention and the women are being educated, and through fertility education, it's a way to help them in getting affordable treatments, and at the same time, it is a source of social support to these women. And we need to think of such type of interventions, keeping in view the context of Pakistan, and make a useful contribution to prevent the suffering of the women. Thank you very much. If there are any questions, I would love to answer.
Thank you so much, Dr. Seher. Audience may ask questions. Okay. If we don't have any question, then we will. We also have a session chair, Dr. Farah Abbasi. Dr. Farah Abbasi, welcome. And Dr. Farah Abbasi is an assistant professor in the Department of Psychiatry at Michigan State University. Her areas of interest are cultural psychiatry, and she works directly with Muslim American community. She is the founding director of the annual Muslim Mental Health Conference. She has also received numerous awards for her service to the community, and the platforms include National Alliance of Mentally III, American Psychiatric Foundation, and Office of International Student Services. She has served on many boards and committees, including Council on Minority Mental Health. She works relentlessly and tirelessly towards one goal: learning to coexist and go beyond our different cultures. Thank you so much for coming. Over to you, Dr. Farah.
So thank you so much. Very, very informative and very impressive presentations. And what really spoke to me on a personal level is how the same themes that I am dealing with in my work, same themes are coming out in your work. So I would like to open up for discussion also, but I wanted to ask specific questions. So on the basis of mindfulness, adaptation of mindfulness, I think you did amazing job in translating, like, you know, when we are translating and adapting instruments, tools, you have to translate it from the primary language to the local language and then retranslate it so that the context has not changed. So I was really impressed by that. I wanted to see that, is it just the mindfulness piece that was effective, or is it just that any support giving, like I think in our culture, stigma causes so much shame and avoidance of mental illnesses, and any intervention will have beneficial impact. So I would request if Anam can talk more about that, or what are the thoughts? Like, is it just the piece of mindfulness, especially, that they felt was helpful, or is it like any intervention, any support, any therapy is beneficial? If Anam is still here.
Am I audible?
Yeah.
Okay. So thank you so much for your question. Yes, this was one of the key things about stigma that was addressed during the intervention and while we were doing the need assessment and when we were taking it to the participants. So though it was not directly like asked to them about this, but this is something that came up in the feedback. They found that this intervention, the mindfulness-based intervention, the way that it was planned in the 8-week themes, it literally did not put the students and their stress and their mental health struggles on the spot. That is, it took away that stigma that is from being like stigmatized at having something of a mental health struggle. So it was something that they came up with, which helps them associate more with the intervention and connect more at a personal level. That they felt that it helped them understand their own self and come to terms with their circumstances.
Thank you so much. So I think when I do this Muslim mental health work, I rely a lot on the strengths of our religion, spirituality, and our culture. So one thing is that mindfulness, we are accepting it like a psychological intervention right now, but mindfulness in itself has a very religious origin, right? We picked it from the Buddhism, but what I feel like mindfulness is very seeped into our religious practices and in our concept of spirituality. So I wonder, like, if that's why people open up to mindfulness more, because we are already trained. When we are practicing a religion, we are already trained in mindfulness. So that feels very natural. So to me, that was a very interesting aspect. Same way, the next presentation I would like to comment was Hajra. Hajra, it's amazing that right now social isolation is being studied as one of the biggest vulnerability. And I think, again, coming back to the strength in our cultures, it was and is, we are very gerocentric. We celebrate geriatric populations. We kind of, the older generation is considered the wise one. We listen to them, we engage them. And I think the trends are changing even in Pakistan with old people home. I've heard some really sad stories as well. But right now, the biggest epidemic in geriatric population is social disengagement and social isolation. The care, the geriatric, so I'm currently running geriatric unit. And I see that the geriatric care has just been reduced to controlling their behaviors, putting them in front of television, or just providing nutrition and medicines to them. And the integral piece of social engagement has to be focused on. So the studies are showing that isolation in itself, loneliness and sense of isolation, is as bad in health outcomes as smoking, drinking, or obesity. So it's almost considered as a carcinogen right now. And we are seeing, like, the studies came out that the cardiac patients who are socially isolated, their mortality increases 4 times. Hospitalization rates are higher. So, like Dr. Megan also mentioned, that unfortunately in America, we are spending so much, but the outcomes we are seeing are not there. Like, we are not seeing that quality of life. So I wanted, like, if you can focus a little bit more on what your findings were and how it's being like right now in realm of Pakistani society, how is it like this social isolation and in geriatric population impacting their cognition?
Okay, first of all, thank you so much for the appreciation, and it was like very insightful. Whatever you just explained, it was really insightful. I would like to add something over here. If you do have time, I just want to add over here, because this was the systematic review based on which I'm working currently on my research. So I've taken topic from this systematic review for my research and this research. So currently, I've also seen that, keeping in view this, as you've said, this social isolation thing. So I've seen this trend that currently in the period of this pandemic, but while going through the studies, I've seen that this pandemic has a very devastating effect on this geriatric population, because the major thing in Pakistan and anywhere else as well, we've seen that social isolation, social distancing is the major thing which we have to keep, which we have to follow, keep, like in order to just, stay safe and all. So I think that has a great impact on the cognitive functioning in all aspects. For example, if they're they're just kept, isolated, so their cognitive abilities are not used. For example, if you talk about Pakistan and very particularly those muhalla systems, if so there are people in older age, sitting together, and if we go in earlier times, so we see this trend that people go and they sit, and our elder people like grandparents and all that, they just sit and they talk, they have a cup of tea, and they have this social interaction. But now with time, it is just, it is decreasing, and we see the lack of that interaction, due to which, if we compare cognitive health of people in previous people in earlier ages, so there is, I think, a noticeable difference which I can see. And also, although it is decreasing, but due to pandemic, it has it's left a very, very devastating effect on the cognitive health of this population.
Also, has the media consumption has increased in Pakistan as well? Has that? Did you see anything there? Any? Because unfortunately, with media, on one hand, you have access to more knowledge and information in an instant, but overall, what we are seeing, that watching these dramas constantly is more numbing impact. It's not really engaging them, but that's the concept here. We feel like, oh, they're watching TV, so they're comfortable, they're settled, but it also takes them away from physical exercise. And that's another thing, I think, in our culture. Right. In our culture, it's like, oh, you are growing older, so you should just settle down. We are not encouraging them to walk or exercise. We are kind of encouraging sedentary lifestyles. But it's very interesting. I think a very good area globally, a lot of interest in it right now. So I would be very interested to see where you take this further. Do you plan to do more research or interventions around it?
Yeah, Abhi, currently I've just taken out a topic from out of this, and I'm working on my research. The topic of my research currently, it is basically the depressive symptoms as a mediator in the relationship between activity and cognitive functioning among community dwelling Pakistani older adults. And in activity, I have divided 3 activities: physical, cognitive, and social activity. And I'm looking at the relationship and the mediating effect of depressive symptoms in this relationship. So I'm currently working on that. So yeah.
Excellent. No, I'm very excited about all the presentations were very impressive. So Sumbul, coming to your work, it's amazing. I'm currently involved with a lot of projects in Pakistan. So I would be very interested to study this project more. But only thing I was kind of wanting to ask you is, one thing is, again, how the stigma was tackled. And secondly, the training, like what was the language? Because I know there are various dialects, right? Happening in like Pakhtunkhwa also has different languages. So you said that some of them were trained in Urdu. How prevalent is Urdu in Pakhtunkhwa? And like, was that a barrier? Language can be very big barrier in accessing care. Was that the thought process to translate the material in different dialects and languages? Or
Okay.
but if you can touch base on stigma.
Okay, thank you so much for appreciating the work. Okay, first of all, about stigma, what we did was that we tried to make mental health simple for people. We tried to keep the messages relatable. Like we didn't talk about nafsati masail per the language that's usually used here. We talked about, can you sleep? How's your appetite? Have you been
Physical
gaining
symptoms,
weight?
right?
Yes, yes.
Right.
Because the cases that are usually reported here relating to mental health do not have psychological manifestations. They have physical manifestations.
Very
So we took it
somatized.
from there. Yeah, and it really helped because people could relate to it a lot. And then coming towards and another thing, that's something that was very dominant in testimonials that people would give us, particularly who would come to the psychosocial support centers, that this new narrative about mental health was very exciting for them, even that mental health in this perspective. So now to look at these things, they like for example, there was this one couple who came to us consistently because the wife was always sick and the relationship was going very, very bad because the wife was always uncamped, the children were all over the place. So eventually when the husband learned that prenatal and then postnatal depression, that went on for a very long period of time till it developed into further complications. So once he understood that, like, it was amazing to see him putting in effort and making the relationship work. So things like that, small incidents like that, told us that we were going in the right direction. And coming to the second part of in Peshawar, particularly and entire KP, people usually know Urdu. It's not like they struggle with it. They know Urdu. Some people may not be able to read it, but most of them can speak it and understand it pretty well. And why we translated the module for lady health workers was because a lady health worker is qualified maximum of bachelor's and a minimum of. So someone who has graduated in the 10th class would struggle with material that's given in English. So that's why we translated everything to Urdu. So all of these were having either matriculation as a degree or they had done bachelor's. And some of them were masters as well later on, but yes, maximum of them. Translated the module into Urdu because the routine curriculum of LHWs is also produced in Urdu mostly. The checklists are in Urdu, their surveys are in Urdu, everything. So we followed the same pattern. We translated all the tools and all the training material for them, and then it was like really easy for them to learn on it. Yeah.
Very, very impressive. Again, I would like to study it more. And because we are very involved in some of the projects, I know I'm running out of time, and I do want to give Sarunisa Hassan a chance. So Sarunisa, again, such an important topic, infertility in women. And we know that women who are depressed, anxious, they do tend to have higher infertility rates. And then having infertility issues can worsen those depression and anxiety situations as well. I wanted if you can touch base on the role of faith leaders, because that's my area that we are working on, is that I feel like, be it stigma to mental illnesses or any other major issues, I would like if you can talk about the role of faith leaders and, of course, a role of supportive husbands. And another thing is we are all living in multi-generational units. Like, we have the concept of combined family system in Pakistan. So sometimes infertility like issues become like kind of a personal like issue with the woman, like as if a woman has some control over it, and she's stigmatized, victimized around it. So those two things, if you can touch base on, would be great.
Thank you very much, Dr. Farah. You have already identified so many other aspects of this experience, and I would just like to add a little bit. There are actually two extremes of this experience. I wanted to actually start my video, but unfortunately, during my presentation, and even now it's not working. Sorry for that. There are actually two extremes of the experience. Either the women are only going to the traditional healers, the faith healers, or either there's a category of the women who are going for the advanced infertility treatments. And both have repercussions. If they chose to go to the traditional healers and faith healers, okay, there may be some success in some cases, but that cannot be generalized. And mostly, in majority of the cases, the suffering is prolonged. And consequently, fortunately, in the past few years, I have seen that some of the media programs are focusing upon identifying so that women just don't increase their vulnerability due to such experiences. And at the same time, there should be more focus. As we talk about the community-based intervention, we should focus upon every aspect of the community which can be engaged to be more contributing, rather be a hazard to those things. And secondly, as I mentioned, that there is another trend of seeking advanced fertility treatments. Women usually carried away by the ideas of IVF treatments and other invasive procedures, and which also has so many negative outcomes, keeping in view that in developing countries, there is no setup for the emotional and the social support after going through these treatments. So rather it become helpful to them, it adds to their stress and poor emotional health. Fortunately, if the woman is educated and she has a good network of friends, then they are at times saved from these things. But most of the times I have seen many stories of sufferings, and there's definitely need to pay more attention to this side of issue. Thank you.
And then, of course, with the infertility treatments, I visited the center in Lahore, and I realized that it has also become a source of gender selection. Like they are going in for a specific gender, like, oh, can I have a son? So yes, that's another. But again, I think very insightful, amazing work that you all are doing. I think I would like to close on just one comment I would make is Michigan State University, and I personally am very invested in work in Pakistan. And if any way we can support any of these projects, I would be more than happy to work and learn from you and bring our expertise to you. So again, I'm really thankful that I was included in this programming today, and I wish you all the best.
Thank you so much, Dr. Farah. Thank you for your gracious time. And you have given wonderful comments to all the presenters. So during this afternoon, we have wonderful presentations. Presenters talked about psychological well-being of university students, cognitive dysfunction of older adults, public mental health approach program for children, and well-being of infertile women. So we would also like to thank Dr. Jade Megan, who has highlighted the importance of global health interventions. Indeed, understanding the concept of well-being may lead towards learning the hurdles towards global health and public health, which, if addressed, will lead to sustainable development for all the countries. So with this, I would like to thank everyone. If there is any comments, suggestions, anything? Okay, thank you so much. With this,
Thank you all.
we will end the session.
Take care. Assalamu alaikum.
Thank you, everyone.
Thank you, everyone. Allah Hafiz.
Allah Hafiz.